Thank you, operator, and thank you to everyone for joining us for the COVID-19 daily media call from May 12th. Governor Walz is not on today's call. We have 45 minutes for today's call before we need to get the commissioner on to her next commitment, so today's agenda is a bit lighter. We'll start with the latest situation update from Commissioner Malcolm. Following that, we will hear an update from MDH Infectious Disease Division Director Chris Ersman. After those updates, we'll open it up for questions from reporters on the line. With that, I'll now turn it over to Commissioner Malcolm.
Thanks, Mike, and good afternoon, everyone. First, do the data update. Globally, early this morning, we were at nearly 4.2 million cases and 286,000 deaths around the world. In the United States, as of this morning, we are reporting just over 1.34 million cases and 80,600 deaths. Here in Minnesota, we announced a new total of 12,494 cases confirmed by laboratory. That was an increase of almost 700 from yesterday, 695 to be exact. We are still we've inched up to a 10-day case doubling rate, which is up from 8 days to double last week. So that is a metric that we look at just to try to have another gauge for the pace of growth. But as we've said many a time, the more we test, the more we're going to find, and that's to the positive, particularly when we're testing in high vulnerability areas. We also sadly announced an additional 23 fatalities from yesterday, bringing our total of 614 Minnesotans who have died of COVID-19 disease. Yesterday's 23 includes 14 people from Hennepin County, 2 from Anoka, Itasca, and Ramsey each, and 1 each in Cass, LeSueur, and Washington counties. The total includes 6 people in their 90s, 9 people in their 80s, 4 in their 70s, 1 in their 60s, and 3 people in their 50s. 19 of these deaths were associated with long-term care residents. There are currently 496 patients currently hospitalized, 199 of those in intensive care. So we are very closely watching those metrics, as you know, to make sure that intensive care capacity in particular is ready to deal with the expected continued increase in cases. I would like to just note that we hit the 5,000 mark in testing volume yesterday, 5,053 tests. Certainly expecting and hoping that number will continue to rise, as we know we've got additional capacity now in the state that is not yet being used. So we want to, again, remind people who have symptoms of COVID-19 that they can and should be getting tested. Please consult that website to find a testing location near you. We will also be using some of the capacity we have and are using some of the capacity we have to do enhanced testing among vulnerable populations and in certain settings, such as long-term care. I'll talk about that a little bit more in a moment here. As Dr. Linfield talked about yesterday, we have benefited from a supply of remdesivir that was distributed by the federal government. We received a second small shipment of remdesivir last night, which using the same allocation kind of methodology that Dr. Linfield described yesterday was sent out, is being sent out immediately today to healthcare facilities to assist with treatment of people who are hospitalized with severe COVID-19. And I won't repeat all of the information that Dr. Linfield shared with you yesterday, but we are glad to be able to get that out to the points of care as quickly as we did. I'd like to talk just for a moment about the kind of our progress report on ramping up the long-term care plan that Governor Walz and I announced last Thursday, which was just an increased statewide focus, not only from MDH, but from many partners on making sure that we are doing everything we can to work collaboratively to support the long-term care provider system that is taking care of residents and workers who are, as we have mentioned multiple times, just challenged with a special set of factors, just given the demographics and the underlying health condition of long-term care residents and the importance of understanding how best to protect them and protect the workers in those settings. So the comprehensive approach that we mentioned last week included 5 kind of key pillars. The first being an expanded testing protocol wherein we will be testing everyone in a facility once there is a confirmed case or more than 2 people with symptoms consistent with COVID. And so that is a priority to ramp up testing in those settings, as well as to create a logistical capacity to help provider facilities be able to access that level of enhanced testing when they can't do it on their own. What we really are encouraging is that long-term care facilities have partnership relationships with healthcare providers currently, and that they be working with those providers to get the testing done as soon as they find the need for it. But part of our enhanced statewide plan is to be in a position to provide logistical support to help make that testing happen when there's not an immediate or pre-existing testing relationship that can be activated immediately. Another pillar is enhancing our support for infection prevention in the facilities and working with facilities to have increasingly detailed preparedness plans, making sure that we can also be a backstop for helping facilities to get additional personal protective equipment when their own supplies run short, although just like with the acute care system, we encourage long-term care providers to be certainly using their own supply chains and doing their own planning for ramping up supplies, but having the state stockpile be a backstop for that as well, and continuing to really push on procurement of more and more supplies so that the state can provide that backstop. And finally, doing everything that we can to ensure adequate staffing for facilities when they reach crises with potentially significant numbers of cases among their staff or among their residents. Again, encouraging facilities to do their own planning for workforce shortages, but we have been and will continue to work on a kind of an emergency basis to help fill specific urgent needs, but also doing more to try to build up a more sustainable set of resources that could be deployed for perhaps slightly longer periods of time as bridge staffing solutions beyond just one shift at a time. As we described the plan, we mentioned that it's very clear in its goals. It's got some specific metrics. We feel very good about the fact that it's building upon what we have learned about this epidemic and some of the best practices that are going on with long-term care facilities here in our state and around the nation. We benefited from some consultation with the CDC, but we mentioned that the plan it now needs to be implemented, and that takes some time. It's unfortunately not something that we can flip a switch and have the plan be fully implemented everywhere in the state immediately, but it is a high priority, not only for MDH, but for our partners at the State Emergency Operations Center as well. I've certainly gotten a number of emails and calls from folks who are concerned and disappointed that the plan isn't fully in place in the long-term care facility that they work in or have loved ones in. Certainly, we understand that everyone's desire to get this in place as quickly as possible, and that is our goal as well. But I just wanted to call out the fact that this is a rather complex process to get this in place all over the state. We're making good progress on it, but it clearly is going to be something that will take some period of days and even weeks before it is fully implemented statewide. Just as an example, ramping up the new testing approach requires that we work with the providers to make sure that they're doing everything they can do to put those mechanisms in place that they can call their local provider partner as quickly as possible, and we will provide some of that kind of backup logistics as needed. Similarly, on the adequate staffing and PPE and testing fronts, that we're working hard with the providers to increase their own level of preparedness and backing them up as we need to. So really the state's role and our partners is to really assist these facilities in meeting their own plans and helping them to overcome obstacles. And I just want to thank the leadership in the profession that is working very hard on this, and our partners at the State Emergency Operations Center, our partners in the health systems, our partners in local public health and emergency management who are helping us to implement this plan. So with that, I'm going to turn it over to Chris Erzman to talk a little bit more about the data that we are looking at and reporting.
Thank you, Commissioner. I'd like to tell you about some updates that we'll be making to our website related to the COVID-19 data that we make available. As you know, we go through COVID numbers every day, and many of you are aware that this data on cases is also available on our website. We know that this data is of interest to a lot of people, and we are always working to make sure the data are understandable and that we're including information that best represents the situation in Minnesota. We are making some updates to our situation update page that will be live tomorrow at 11 a.m. with our usual daily update. And so I wanted to provide you with a quick overview of the updates. First of all, at the top of the page, there will be a box highlighting our overall cumulative case count for the state, as well as information on new cases and new deaths being reported that day. This information has been on the site, but it will now be at the top of the page to make it easier to find at a glance. The data on new cases for the day will also include a note when cases have fallen off the list. And let me just explain about that. As has been noted on the website from the beginning, all data are preliminary and may change as case investigations progress. Sometimes during case interviews, our investigators find out that information initially received needs to change, such as discovering a person who tested positive in Minnesota actually lives in a different state, or a test turned out to be a false positive or a duplicate record. This data quality assurance is important to make sure the final count are as accurate as can be. And during any outbreak situation, cases can come off the overall count when new information is discovered. So this isn't something new. It's just that we are providing data on a daily basis and very quickly. And so we don't have the luxury of saying these are the numbers from 2019 or 2020. We're reporting things as it's happening. And as a result, we will be letting you know as we get new information or there's a change in the count based on the new information that we've received. Since the beginning of the outbreak, just under 70 cases have come off the total. And as I mentioned, these cases have already been removed from the overall case total, so it does not change any of the case counts. But we just wanted to explain that we will be outlining or highlighting that information. Another change that we implemented last Friday was adding details about newly reported deaths on the website. The details include county, age group, and residence type, whether they lived in a long-term care facility, private residence, or another setting. Then we're also going to be updating information that we provide about the specimen collection date instead of reported date. So what that means is, for our graph, our epi curve that shows the total positive cases over time, we have been displaying this graph based on the date that the case was confirmed at MDH. We're going to make a change, and that graph will now show cases by the date their specimen was collected. That's the specimen that was tested and determined that they were positive for COVID-19. Using the date that a specimen was collected is a measure that's more relevant to each case and is in line with how other disease data is reported. And it gives us a better picture of what's happening with COVID in Minnesota over time. Reporting cases this way removes the factor of reporting delays. In other words, for some out-of-state laboratories, it can take up to a week to get results. So it removes the factor of reporting delays and investigation timing, and more accurately reports when people in Minnesota had COVID. Again, this does not change our total case count, just the day that the case shows up on the graph. So for example, if we confirmed a case on May 5th that actually had its specimen collected on May 1st, that case would now move from showing up on May 5th to May 1st in this new graph. We're also making some changes to data related to release from isolation. We know that there was some confusion about the patient's release from isolation measure. This number includes people who no longer need to be isolated, meaning they were sick and are now not considered to be infectious. This number also includes deaths. The new image on the website will better indicate these two things. We're also including information on probable deaths. Deaths reported on the website include deaths for those who have died from COVID-19. We know they had COVID-19 because there was a positive test result to confirm this. There have been some instances where a death certificate lists COVID-19 as the cause of death, but we do not have a positive lab test to confirm this. Those deaths are now being counted as probable COVID-19 deaths, and this number will be listed separately on the website. Since there is not a positive lab test to confirm these probable deaths, this number is not included in our total positive case count. In conclusion, the other item that will be starting on Thursday is a weekly data report that will include some additional information for Minnesota cases that will be updated on a weekly basis. Some of the information in the report includes more demographic information, data on reported symptoms, and more information on cases among healthcare workers. Since we know there is such an interest in this data, I want to acknowledge that our ability to test has just recently increased. So we know that these numbers do not represent the total number of people in Minnesota who have or at some point had COVID-19. As we have said for so long, the positive cases are just the tip of the iceberg. We will continue to track and analyze data as we do with other diseases and use that information to teach us more about COVID-19 and its impact on the people of Minnesota. Thank you, and I'll turn it back over to Mike Schomer.
Thanks, Chris. We'll open it up for questions now, and as we do, we'll ask that reporters limit questions to one primary and one on-topic follow-up, and that you limit the number of questions from each outlet so we can get to as many outlets as possible. With that, operator, we're ready to take questions.
As a reminder, to ask a question, you will need to press *1 on your telephone keypad. Again, that's star, then the number 1 on your telephone keypad. Please stand by while we'll compile the Q&A roster. Your first question comes from the line of Tim Nelson from NPR News. Your line is now open.
Yeah, I was looking at the case counts today, and I see that Stearns and Nobles County are dropping down again, but we're seeing some upticks, granted smaller, in Candy, Ojai, and Chippewa counties. I assume that some of this got to do with poultry processing. Do you know anything about what's going on in those two counties?
I'm gonna invite Chris to comment on that, and since it's just the two of us today, Chris, just feel free to jump in at any time. Don't wait for me to invite you in. And before I turn it over to you, I just want to say thanks to Chris and her colleagues for just the incredible work that they're doing, as always, on tracking and understanding and digging into everything we can know about the patterns of this epidemic in Minnesota, this pandemic. I appreciate all the work they're doing to make the data accurate and clear and useful to the public. So thank you, Chris. And now I'll turn it to you to answer that question on these couple of counties that Tim asked about.
Yep. Thank you. You're right. We are seeing there was very targeted testing that was done in Nobles County, as I think most people are aware, as well as in Stearns County related to processing plants, and we're also seeing increases in Candy, Ojai, and Chippewa counties for the same reasons. There's also testing that's being done in those areas related to processing or manufacturing.
And do you, we saw some pretty remarkable increases in Stearns and Noble, Chippewa is almost quadrupled in 5 days here. Do you expect that we may see another hotspot there?
Well, as we've talked about, any time that we have COVID introduced into a setting where people are close together, whether it's congregate living or a congregate care setting or a workplace, an essential workplace where individuals don't have the luxury of working in an office, working in a cubicle, or working from home, there is a greater potential for spread. And so when we start to see cases in those areas and there's more testing done, we do find more cases. And so, yes, I think we can expect that we will continue to see cases. I think what's important is the cases are being identified and they know that they're positive and they can take action to isolate themselves.
Thank you.
Your next question comes from the line of Theodore Kitt from Fox 9. Your line is now open.
Hi, Commissioner. As you know fully well, we're 5 days away from the end of the stay-home order. I'm hoping you can confirm for us, will we hear the fate of that order tomorrow? And as part of that, I'm wondering, have you advised the governor a similar message that Dr. Fauci said this morning in the Senate hearing, where he said that when you start to reopen the economy, there will inevitably be more cases. Cases will go up.
I will just need to refer you to the governor's office in terms of timing on when he will be making his decision and communicating that. You could check with his office on that. Certainly, I think, and I'll confess I haven't heard Dr. Fauci's statement yet. I've been in meetings all day so far, but certainly that I think is sound advice and what we would expect, that just as we start to see more interactions in the community, more contacts among people, it's quite natural to expect that with as little exposure as we think the population has had so far to the disease, to the pathogen, that we will see increased cases as that happens. Our whole goal is to make sure that happens in a way that is measured and that the healthcare system is prepared to respond to.
Thank you.
Your next question comes from the line of Jeff Wagner from WCCO. Your line is now open.
Thank you for taking our call today. Have we seen any cases of this mysterious inflammatory disease among children in Minnesota? Are we doing anything in particular to monitor for it? What should parents be doing? I guess would be our question there. Potentially, this disease is potentially linked to the virus with children.
Chris?
Yep. Yes, we are monitoring for this, and it's extremely rare. So I think that at this point, parents who, if your child has COVID-19 and then experiences additional subsequent concerning symptoms, you should be reaching out to your healthcare provider just like you would. But it's an extremely rare complication, and so we are aware of it, and we are setting up surveillance so that we can be monitoring for this. But I do want to reiterate again, just that this is extremely rare.
Thank you.
Your next question comes from the line of Matt Sepik. Your line is now open.
Hi there. I have more questions today about testing. One of my colleagues said that she had spoken with the spouse of a healthcare worker who's working in rural Minnesota, and this person's been turned away for testing. Other people have been turned away from testing. And many testing sites in the Twin Cities still have some pretty strict criteria in terms of who can get tested. Are these restrictions coming from MDH? Is this something that the health department supports? Why are some providers testing. Others are still turning people away, even though we have reached that 5,000 test goal today.
Well, certainly the guidance that we've given to all the providers is to be testing all symptomatic individuals, so that there shouldn't be any confusion about what the guidance from MDH is. We know that some providers, however, will not be able to test a person on a given day for various reasons, but ideally they would be helping to connect that person or refer that person to a site where they could be tested. So we are certainly just going to reiterate that message and that plea that, and certainly apologize for the frustrations that people have when they are having trouble getting connected to a test. Certainly, there is still the criterion around having symptoms, and sometimes folks are wondering, well, why is that important? And Chris can comment more about this, but it is certainly possible that if somebody is asymptomatic, they could get a test and be shown to be negative because they don't have enough detectable virus yet. So there's a clinical reason why waiting to test until you're symptomatic makes sense. It isn't just a matter of conserving resources. It's also kind of considered best practice in terms of the accuracy of the results. Chris, would you want to add anything to that?
I will reiterate the commissioner's comments that we do apologize for that frustration in terms of having people not be able to get testing. If a clinic is having difficulty, they don't have adequate testing capacity, they can certainly reach out to the state and we can talk with them and make sure that they're aware of all their options for testing. And then, yes, in terms of testing asymptomatic individuals, we really want to focus on individuals who are symptomatic, particularly when it's a one-off situation, if you will. So in other words, we have done testing in a facility processing plant where we know that there are cases, multiple cases, and then there's been testing of everyone in that facility, or as we're recommending going forward with long-term care. But if it's just a person in the population who doesn't have any symptoms and wants to be tested, it doesn't make sense to do that because they could test negative today and end up being positive tomorrow. And so it's a single point in time. So we really want to make sure that we're focusing on symptomatic individuals. But I would say for the healthcare system that is having challenges in terms of their testing capacity, I would encourage them to reach out, and we can certainly work with them.
Okay, and I should note. Oh no, sorry, Commissioner, go ahead.
Well, I was just going to reiterate the testing command center that we talked about when we announced the kind of the lab system partnership a couple of weeks ago. Now, it is functioning. It's operational, and it exists for exactly this reason, to try to make sure that we get daily reports from 30 labs around the state as to their capacity and where they might need supplies in order to be able to utilize that capacity. So that system is up and running and should be a helpful resource to help providers be able to get their patients tested.
Now, I have a follow-up question, too, about these drive-up test sites. Who's deciding where they will be? And given that there are many vulnerable people, particularly in public housing here in the Twin Cities, who do not have cards, is there any thought given to taking the tests to these vulnerable populations, people who aren't living in long-term care facilities but may be in high-rise apartment complexes with a lot of other vulnerable folks?
Certainly the answer to that second question is yes. We are looking at outreach strategies to do exactly as you suggested, to make sure that we're going to get the testing where the vulnerable populations can actually access them. And in terms of where drive-up locations are located, to this point, and it's certainly something we will continue to look at from a public health perspective as well, the healthcare systems have been taking the lead on putting up drive-through systems where they have patient populations or where their own data suggests to them that there is a demand. But so we've not, with the exception of some of the workplace special testing that Chris has described, we've not, to this point, set up drive-through testing from a public health system perspective. We might consider that when we get into trying to do some sampling for the purposes of doing that surveillance work that we talk about.
And sorry, Chris.
I was just going to add to that one thing that has been a really important element of the drive-through testing that healthcare systems have provided is the fact that there is a clinical presence. So even though they have made testing available in a very efficient manner for people and in a manner that really limits contact with others, there is a healthcare professional, meaning a clinical person, to evaluate the individual that's coming through. We think it's really important that there is that evaluation, because although a majority of individuals with COVID have very mild symptoms, not everyone does, and so we think it's important that testing is linked in conjunction with that connection to the healthcare system and a provider who has a chance to evaluate the patient, albeit briefly, before the testing.
And real quickly, when can we expect to see testing at, say, senior high-rise complexes that are not long-term care facilities in Minneapolis and St. Paul? Are you doing this, planning to do this in a proactive fashion, or are you waiting for a certain number of cases or an outbreak at these facilities?
I'll just say there's a group looking at strategies to expand that testing in vulnerable populations. We'll get back to you with a better answer than I can give you right now. But I know that there is a group looking at that and talking with our local public health partners about what they would advise. But I think the core of your question is right on. We need to be going to the population.
Okay, thank you.
Your next question comes from the line of Greta Cole from MinPost. Your line is now open.
Hi, I've got a question. Just wondering if you have any sense of what share of the Minnesota population you think has come into contact with the virus at this point. I know the second week of April, when the model was last publicly unveiled, people were saying it could be as many as 100 times the number of cases that were confirmed. With 10,000 confirmed cases, that would be up over 1 million. But of course, more people are getting tested now, so that number might not be accurate anymore. I've also heard 5%. Is there any sort of updated thinking on that?
Chris, I don't know what your sense is, but certainly when we get the latest run of the model, which we do expect in the next couple of days here, I know the university team is working hard to finish getting that in shape so that it can be. I know that's something the governor wants to see, and you're eager to see. We'll look forward to sharing that. But yes, there should be an additional piece of data coming out of that next run about what mathematically is estimated as the case detection rate or the level of infection in the population. But Chris's instincts are pretty darn good. So I would invite her to comment just from her on the ground experience.
Well, I won't make a projection, but I think you made a really excellent observation that as we have increased testing capacity, the proportion of cases that actually have been tested will increase, and so we aren't projecting quite as many that have gone undetected. However, we know that not everyone who has COVID has been tested in the past or will even have the opportunity to get tested now, going forward. So we know that our testing is not going to pick up on every single case, but as the commissioner said, once the model is updated, it will likely pull back a little bit. We've got a couple factors that are into play. One is we're seeing transmission happening, which we know has been ongoing, but we're seeing it in some of these facilities where there's a greater opportunity for spread amongst more people. So that's one thing that is increasing the cases that are out there in the transmission. But then by the same token, we're actually testing those people as well. And so, the number of undetected cases goes down a bit more when you're doing that concentrated testing. So that's an answer to say that I'm not going to prognosticate, but that you had right instincts in terms of recognizing that as we test more, we're going to have obviously more data on the cases, so our projections won't be quite as perhaps large as they have been in the past.
Thank you. And then just really quick follow-up, do we have a firm date on when we can expect an update on the model?
Well, I think as the earlier question was about the governor's timing, which I need to refer you to the governor's office on, but certainly the university folks are working to make sure that new run is available to the governor. So it will most certainly be in the next couple days.
Thank you.
Your next question comes from the line of Glenn Howard from Star Tribune. Your line is now open.
Thank you. Senator Benson and Representative Scott this morning raised concerns about the hospital's Syndromic Surveillance program, saying that it goes against the Minnesota Health Records Act and that MDH did not approach the legislature with any information about this before implementing the program. How is the program justified, and is this an open-ended thing, or will it end when COVID ends?
I'll start, and certainly I'll invite Chris to comment as well. Certainly want to assure the legislature and our legislative leaders that we believe that syndromic surveillance, which is a very core public health tool used in the prevention and control of many diseases, is squarely within our public health authorities and is supported by HIPAA in the Minnesota Health Records Act. At least that's the firm belief of our legal counsel. And I want to assure the legislature as well that the information that is provided under a syndromic surveillance program is aggregate data only, not on specific people. We don't receive any identifying information on individuals, and that the information that's provided under this particular application of syndromic surveillance, where we're looking for early reporting of symptoms that have been shown to have a strong association with COVID, that I just would like to comment a little bit on the value of this tool. It helps us to identify outbreaks earlier than would be possible through disease-specific testing alone, helps us to monitor trends, it helps us to spot hotspots as soon as we can, and I think everyone would agree that there's value in doing that. We know, again, that many of the people who eventually are confirmed to have a COVID-19 diagnosis experience some pretty common symptoms. And so when these folks with those symptoms come into a hospital emergency room, there's great value in having some advance notice of that effect so that we can, again, look for potential hotspots and get regional information as to what's going on to help us better respond to the pandemic and to really, zero in on those hotspots as early as we can. Chris, would you have anything that you'd like to add?
The only thing that I'll add is simply that syndromic surveillance is a tool that we have used in the past and use throughout public health as a useful tool for tracking things. And so obviously a lot of the things that we do are much more of interest to the public, but just to be clear that this syndromic surveillance is not something that is new just for COVID-19. This is a tool that helps public health identify issues for other areas in public health beyond just our response to COVID.
But isn't this syndromic surveillance program for hospitals itself new in that it requires routing of data through DHS or these other two vendors?
Yes, this particular syndromic surveillance is new, but the idea of doing syndromic surveillance and syndromic surveillance as a public health tool is a tool that we have used in the past. And so I just want to be clear that this is not something that was just initiated for COVID in terms of the concept of syndromic surveillance and using aggregate data to help pinpoint and identify things that are happening without having to use individual patient identifiers.
Thank you.
Operator, we have time for one more question.
Your next question comes from the line of Darren Stevenson from Cato Radio. Your line is now open.
Thank you. There was a study that came out from New York last week from the hospitalized patients in hotbed of COVID-19 in this country. And it said 66% of those that ended up in the hospital contracted COVID-19 at home. Has there been a similar study done, or are we even to that point here in Minnesota to get numbers like that? And being the fact this was the hotbed of COVID-19 in the country, do those numbers surprise you at all?
Chris, I'll turn that to you.
Yep. So in Minnesota, we have not done that type of a deep dive at this point, but what I can tell you is that because we have focused our testing on certain areas of the community, in particular long-term care, some of our processing plants, we would expect that we might not have that same high number. Obviously, a resident in long-term care, that is their home, but it would be probably classified differently in the data. So we may not see that same type of result just simply because of the populations that we have been testing in Minnesota. But certainly we know that that close household contact is really significant in terms of transmission. And in fact, the type of contact that we see in congregate settings, it mimics or it mirrors what you'd see in a household. So that makes absolute sense. It's just that in Minnesota, our testing capacity has been more limited, and we have focused it on congregate care settings, on jails, homeless shelters, congregate living settings, and then we've also focused on workplaces. And so we may see slightly different data, but the principle is the same, and that is that close type of contact that you see in a household is really where you see transmission.
Just one quick follow-up here. And again, this is an early virus, as you guys have talked about a lot, and there's more questions that haven't been answered than have been answered. But if close contact is such a spreader of this, why are we keeping people at home and discouraging people from going out based on these orders? Would it be fair to ask, is that contrary to basically what we're saying keeps this virus from spreading?
I would say I don't think that our recommendations are inconsistent. And the reason for that is that close contact does not necessarily have to just be, with the people that are in your household. It can be other individuals that you are spending a great deal of time with. And so what our goal is to limit the number of exposures that any individual has and allow our healthcare system more time to prepare. So that would be my response. But the commissioner was about to speak, and so I will let her answer.
Yeah, thank you, Chris. I think that's accurate, and certainly we've talked too, just not only about the vulnerability of the folks who might be directly interacting, but then the folks at higher risk that those people also interact with. So it's been very motivated by trying to understand those patterns and trying to protect the most vulnerable, and as Chris said, to assure that the healthcare system can prepare for what we still expect to be a significant number of people being infected at one time at the peak and needing a lot of hospital care at the same time.
Thank you.
That's all the time we have today. I want to thank our speakers and the reporters on the call. If you had a question we were not able to address, please feel free to reach out to our office by calling 651-201-4989. Have a good day, and we'll talk with you again soon.
Find more local news stories at ccxmedia.org and follow us on social media.